Welcome to Bacteremia. This is chapter 36 in our Mahon book. We're going to start out with some definitions. Pseudobacteremia is false bacteria, and this refers to the contamination of a blood culture during or after collection. So we're going to have to be able to tell the difference between a true pathogen in our blood cultures and a contaminant. Bacteremia is the presence of bacteria in the bloodstream, and it usually occurs from a disruption of skin or mucosal barriers due to bacterial invasion. So we're going to classify bacteremias based on the site of origin, the causative agent, the place of acquisition, and also the duration. So what does this mean? Primary bacteremia is where the bloodstream or endovascular bacterial invasion has no preceding or simultaneous site of infection. That means it's infected, it gets into your bloodstream directly, like from an effective heart valve or an IV catheter. Secondary bacteremia is when you get isolation, when you isolate bacteria from a blood culture and other sites. For example, if you have a urinary tract infection with E. coli and you have E. coli that grows in your bloodstream, that is a secondary bacteremia. Then we have fever of unknown origin. That's where we don't know the source. So the causative agents, it can be classified as a gram-positive bacteremia, a gram-negative bacteremia, an anaerobic bacteremia, or polymicrobial bacteremia, which means that there's an infection with more than one organism. So examples of cases of when this can happen is burn patients, IV drug users, and if there's a GI tract problem, like if there's a rupture or something in your GI tract. And classification by place of acquisition, we can have community acquired, which means you just got out and about at home, not in the hospital, and then healthcare acquired or nosocomial. And you have to have developed this after 72 hours of being admitted into the hospital. And classification by duration, transient, that means it comes and goes, usually occurs after a procedural manipulation like a dental procedure. Intermittent, it can occur from abscesses at some body site that is seeding the blood intermittently. And then continuous bacteremia, where organisms from an intravascular source are consistently present in the bloodstream. And an example of that would be endocarditis. That's the most common manifestation associated with continuous bacteremia. Sepsis and septicemia. There are two potential consequences of bacteremia: sepsis and septicemia, or septic shock. And this is indicated by the presence of active bacteria resulting from continuous bacteremia and the clinical signs and symptoms of bacterial invasion and toxin production. And there's a systemic response to bacterial infection, and it is really bad. Septic shock results from the body's reaction to bacterial byproducts like endotoxins, which are the lipopolysaccharides from our gram-negative bacteria, exotoxins, and these can disrupt many body functions. There can be blood pressure changes, organ and tissue damage, shutdown, and there's a mortality rate of 40 to 50% from septic shock. So what factors contribute to bacteremia or septic shock? Immunocompromised patients, and this is due to a decrease in circulating neutrophils. There can be an increased use of invasive procedures and indwelling devices, like if you have a port put in for some type of chemotherapy or treatment. Those can disrupt normal flora. The age of the patient, so for the young people, there's a defect in humoral immunity. They haven't completely developed that yet. And then for the older patients, there's a decrease in immune competency. Also, administration of drug therapy can also be a factor or a risk. What are the sources of bacteremia? So where do these even come from? Pericarditis, peritonitis, pneumonias, pressure sores, prosthetic medical devices, knee or hip replacements, the skeletal system, the skin and soft tissue, if we can get an abscess, and urinary tract infections. Those are all can be sources of bacteremia. What are the signs? Abrupt onset of chills and fever, hypothermia, so coldness, and hypotension, so your blood pressure drops, exhaustion or weakness, and extensive sweating or perspiration, rapid breathing, that's an early sign of bacteremia, delirium, and then nausea and vomiting. So what are we going to see in the lab? We're going to see decreased platelets, increased white blood cells, or a really low white blood cells if they're all wiped out, acidosis, abnormal liver, coagulation problems, maybe DIC, elevation in our inflammatory reactive proteins like CRP, haptoglobin, fibrinogen, sedrate, procalcitonin. Procalcitonin is a great newer test that indicates infection. So what specimens will we see? Well, blood cultures. And there are very few critical values in the microbiology lab, but positive blood cultures is considered a critical value, and the physician needs to know immediately. So the physician will correlate findings of the clinical picture to verify septicemia. The best practice is to collect the blood culture specimens immediately prior to a rise in temperature, but how can we know that the temperature is fixing to spike? We don't. Also, collect prior to antibiotic therapy with very good aseptic collection. So how do we prepare for aseptic collection? We can use tincture of iodine, which is 1 to 2%, leave on 30 seconds at least. Povidone iodine solution, which is 10%. Chlorhexidine or ChloraPrep. Cleansing techniques, we're going to move in concentric circles from inside to outside. Wait 1.5 to 2 minutes for everything to dry. Don't fan it. And this is kind of shocking, but necessary. The acceptable contamination rate is 1 to 3%. And there's been a constant back and forth between lab and nursing. Some hospitals only allow laboratory staff to draw blood cultures, and some hospitals allow nursing staff to draw blood cultures, but contamination rates seem to be lower when the blood culture collection is left to laboratory employees. Collection sites for blood cultures. The preferred sites are the peripheral venous sites. So I have this picture here in the upper right. Less common, central venous catheters, which can be from IV lines or ports. That's less common, but acceptable. Blood culture devices, there's a traditional set. Usually there are 2 bottles, an aerobic bottle and an anaerobic bottle. So the aerobic bottle will select for aerobic and facultative anaerobes. The anaerobic bottle will select for obligate anaerobes. And there is usually an ARD bottle, that stands for antibiotic removal device. And the anticoagulant that's used in blood culture bottles is usually SPS for sodium polyanethyl sulfonate. That's a long one, but we are just going to say SPS. What does it do? This SPS, it neutralizes neutrophils or phagocytes, not just neutrophils, but all the phagocytes, and inactivates certain antibacterial agents. So how much blood do we need to draw in these blood cultures? The ideal ratio of blood to the broth that's already in the bottle is 1 part blood to 5 parts broth, or 1 part blood to 10 parts broth. The dilution aids in preventing the bactericidal effect of the white blood cells in complement. So that dilution is not necessarily to help the bacteria grow, it's to prevent white cells and complement from doing their regular job. The volume recommendations depend on age, so if the patient is younger than 10, 1 milliliter of blood for every year of life. So, for example, if you have a 3-year-old, you would need to collect 3 milliliters. For 10 years and up, 20 milliliters per bottle. And if there is a short draw, or if you anticipate a short draw, which bottle should you collect first? Well, anaerobic. The anaerobic bottles should be first, just in case you only get one. How often do we need to collect these blood cultures? It depends on if the bacteremia is transient or continuous, but usually you're going to draw blood culture times 2 from different body sites when a patient is spiking a fever. In the cases of endocarditis, you would need 3 sets from 3 different sites within 1 to 2 hours of clinical presentation. And for fever of unknown origin, you're going to collect 2 sets and then 24 to 36 hours later get 2 more sets. So that would be a total of 4 bottles the first day, and then 1 to 2 days later, 1.5 days later, 4 more bottles. All right, so if there's a catheter-related bloodstream infection is suspected, you want to draw 1 peripherally, 1 set, so 2 bottles peripherally, like from an arm, and then the other set would be drawn via catheter. So how do we do blood cultures? There are conventional broth systems that we're going to talk about, but back in the old days, you would just collect blood in a bottle and then invert, incubate, and then every day you'd have to be subculture. You'd have to subculture or gram stain at the end of 12, 24, and 48 hours. This is not recommended because it's time consuming. You have risk of needle stick and contamination, and it is not cost effective. So the next thing that came along were biphasic blood broth slide systems, where these auger paddles attached to the top of the bottle, and it would allow for blind subcultures, but it was a closed system. I've never seen one of those in person. We're not going to talk about this one, but this is what you're going to see when you go to clinicals, and this is what they're using in the real world. There are automatic blood culture systems, and there are different companies, and we're going to talk about a couple of them, but the Bactec 9000 series, they use a fluorescent light to detect carbon dioxide level changes. So the theory is, as bacteria grows, carbon dioxide is produced, it's going to cause a color change, and this fluorescent light is going to detect when there's a color change. Then the computer is going to detect that change and send a message, and the alarm will sound, and so you'll have to go find the bottle, do a gram stain, and subculture. And here's a picture. So each one of those dark circles represents a spot where a blood culture bottle would go, and it continuously rocks back and forth. The next system is now Versatrek. It measures the consumption or production of gases such as carbon dioxide, hydrogen gas, nitrogen, and oxygen in the headspace of each bottle, and it detects a pressure change. So it's the same type deal. The computer is detecting these pressure changes, and then it alarms, and it tells you where the bottle is, and you go and pull it. BactAlert is a carbon dioxide production change, so it results in a pH change. And the pH change results in a color change, which is detected by the system as positive. So again, there's a light in here that detects the color change, and then an alarm will sound. How long do we hold blood cultures? For routine blood cultures, 5 to 7 days. For they're going to order specially if it's a fungal culture or something. But for endocarditis, it would be held for 2 weeks. But for brucella or fungus or haystack organisms, 21 to 28 days. For reporting of results, the initial report is sent out at 24 hours. And what that means is usually if you are working on the weekend, this is going to be one of the first things you want to do if it's not automatic already. You're going to want to come in and update your blood culture reports. And that's going to mean that any blood culture that is active will be added they'll add 24 hours to it in the computer. So at 24 hours, everything that's 24 hours old, every blood culture that's 24 hours old, will automatically result to the computer as no growth at 1 day, or no growth 24 hours. So if you don't do that in the morning and you're working on a Saturday, you're going to get some phone calls about your blood cultures. The final report is sent out at 5 to 7 days that says no growth. What do we do with the positive cultures? The first thing we do when that alarm goes off, we go pull the bottle and we're going to make a gram stain to determine the morphology of the organism present, and be very careful. These blood cultures, the bacteria can look weird. The stain may not act perfectly, so you have to be very careful and remember, think about what you're expecting to see in the blood cultures, what's likely. Then you're going to call the results of the gram stain to the physician or nurse, including how many sets or which bottle. So you'll say, I have one bottle positive from Mr. Smith, and it's a gram-negative rod. Or likely they'll start becoming positive pretty quickly. Or you'll call and say, I have 2 bottles positive from, and so forth. So then you subculture, you take a needle and syringe and you remove some of the blood from the blood culture bottle, and you inoculate blood, chocolate, definitely a blood and a chocolate, subculture that, and then grow that up, incubate overnight, so the next day you can do ID and sensitivity. What are the common blood culture pathogens? Staph aureus, strep pneumo, Haemophilus influenza, Pseudomonas, Neisseria, coag-negative staph, group B strep, strep viridans, and other alpha hemolytic streps, gram-negative rods, yeast and molds, and anaerobes. Those can all be pathogens. But what about the contaminants? So the contaminants are most likely going to be coagulase-negative staph, Propionibacterium, alpha hemolytic strep. So remember, coagulase-negative staph and alpha hemolytic staph can also be pathogens. Bacillus species, diphtheroids, and then if you have more than one organism, it is most likely a contaminant. So how do we treat these? Antibiotics, of course, but how do we prevent some of these? Vaccines, definitely. And that concludes our bacteremia lecture.